Welcome to this webinar organized by the European Reference Network for Neuromuscular Disorders, EURO-NMD, in collaboration with the European Reference Network for Neurological Disorders and with the European Academy of Neurology. Today we are talking about management of HyperCKemia, and we are lucky to have with us our friend Professor Antonio Toscano, full professor of neurology at University of Messina, Department of Clinical and Experimental Medicine, and director of the Regional Reference Center for Rare Neuromuscular Disorders at the Policlínico G. Martino. After graduating in medicine and specializing in neurology, trained as a postdoc fellow in London at National Hospital for Nervous Diseases and at the St. Bartholomew's Medical College. His interests are varied, focused on mitochondrial disorders and to neurogenetic diseases with expertise in metabolic and genetic myopathies, mitochondrial disorders, peripheral neuropathies, and neurodegenerative diseases. Professor Toscano has held leading roles in national and international societies, including being president of the Italian Association of Myology, the Scientific Committee of the European Academy of Neurology, and chairman of the European Academy of Neurology Muscle Disorders Panel, and serves on several editorial boards. He has obviously lots of publications, more than 160 in index journals, and we are very lucky to have him from time to time to explain to us the intricacies of these diseases. Antonio, thank you for accepting this invitation, and the floor is entirely yours.
Thanks very much, Antonio, for this very and too kind introduction. So my role is today to update the colleagues about the management of HyperCKemia. I can just would like to premise that you'll see some very, very new data, because we are going to have the publication of guidelines of HyperCKemia in few days, hopefully. And I am allowed to show you the results that are included during my talk, that are included in this new paper. So just to start, I would like to clarify some terms, because sometimes there is a little bit of confusion. And HyperCKemia is considered a persistent and or recurrent elevation of serum CK due to a continuing muscle injury. And sometimes this term is confused with the rhabdomyolysis, which is a pathological phenomenon that evidently can make a great increase of CK, usually within 24 hours, and with the progressive decline by 30–40% per day after the onset. And finally, myoglobinuria, that very often is present when there is HyperCKemia or rhabdomyolysis in over 250 mg per liter in urine. So what is usually defined as by the Anglo-Saxon literature, dark urine or Coca-Cola-like urines. In this very quite known slide, you can see that there are several different kind of muscle disorders, but not only muscle disorder, but neuromuscular disorder. There's in larger terms that can produce an elevated serum creatine kinase level, and you can see muscular dystrophy, limb-girdle myopathies, metabolic myopathies, but even less known disorders like neuroleptic malignant syndrome or compartment syndrome that I will show you a case later. CK is often accompanied by myalgia, muscle tenderness, weakness, muscle edema, which, if is too rapid, provoke the risk of hypovolemia. Compartment syndrome, again, characterized by swollen muscle, and it's not only the swollen muscle that has to be considered, but also the compression in the surrounding tissues that can be considered very dangerous for the integrity, the muscle integrity. HyperCKemia, metabolic acidosis, acute renal failure, and even in very specific and very severe cases, disseminated intravascular coagulation. And in the few years ago, there was an attempt to try to better define hyperCKemia, and there was this famous Tromso study. This has been developed on nearly 3,000 individuals. And after the first step of the study, 5.3% were considered to have hyperCKemia, but after a very accurate study, only 1.3% showed persistent hyperCKemia, because the others normalized very, very rapidly, or at control there was no hyperCKemia in the remaining individuals. And this was something that really stimulated other researchers, and we wanted to try to make a little bit of order among the literature in the last few years, and this is a very recent paper on European Journal of Neurology done by the group that also has produced the guidelines. And this study produced some interesting results. You see that the idea was to determine the general normal CK levels in healthy adult in a population healthy adult over 18 years, across different ethnic groups worldwide, and either for male or female subjects. And you see that we look into a very high number of publications, but what was the residual number of publications? About 20 observational studies. They included over 50,000 participants from every part of the world, and the database were coming from PubMed, Embase, and Cochrane. And you'll see that the results were not really surprising, because we had some previous studies like Tromso studies and Brewster studies. But what is important is to outline that there is a difference between the normal levels if you consider Asian population and Caucasian population, which are very similar in terms of results. But if you take Black individuals, they have a higher CK either in males or in females. This is quite important, because it can explain sometimes some surprising results obtained in these different populations. And summarizing the results, there was no significant difference, as I said, between Asian and Caucasian population, but the values of African descent were higher. CK levels decreased after 65 years. And we have to include also that there were some confounding factors that sometimes can change the CK expression, like physical activity, drugs, or muscle mass. In conclusion, the normal CK values were found a little bit higher than traditionally reported, but we would advise to establish local reference intervals, and this has to take into account also race, sex, and age. But we also have to consider that misdiagnosis of hypercikemia in healthy individuals should be avoided too, not to prolong studies and laboratory examination for individuals that are completely healthy. And it is at the moment, as I said, we are very close to the publication of the new guidelines. And after these studies, we wanted to express the interest of establish new guidelines, because general and neuromuscular neurologists are really involved in the problem of hypercikemia to try to define individuals with hypercikemia. These individuals may present also with muscle stiffness or muscle pain, fatigue, contractures, and with high or normal, even normal CK. The initial presentation can be asymptomatic or oligosymptomatic with hypercikemia, and it is really needed a guideline to better investigate individuals with oligo or asymptomatic hypercikemia, to really supply accurate proposals, accurate addresses for diagnosis. So just finally, appropriate diagnosis, it's of course very important for the individuals that have hypercikemia, because once you discover their diagnosis, you are able to give them timely therapy and also to improve their quality of life. But let's see what happened in the past. So this is the first guideline for hypercikemia that has been produced by the group of EAF, the European Federation of Neurological Societies, some years ago. And in that case, they pointed out specific clues like hypercikemia with no primary muscle disorders, CK even normal in some kind of myopathies, and asymptomatic hypercikemia in some mainly genetic myopathies. These were some important points to be elucidated. And the results of this first study was that hypercikemia was defined as 1.5 times the upper limit, the normal limit recognized. The recommendation was to repeat the assay of CK, avoiding any kind of stressing for muscle after a week, and at least twice in a month apart. And also important, the advice of inquiring the family, try to understand if there was a family history or other subjects with hypercikemia and or malignant hyperthermia, that, as you know, is a very severe problem for individuals with possible myopathy. And the overview of the literature was centered on muscular dystrophies, metabolic inflammatory myopathies, and also other kind of neuromuscular disorders like neurogenic, but also to consider a list of non-neuromuscular diseases. According to these addresses, there were some attempts in several parts of the world to study a large population of patients with hypercikemia. This is one of this kind of possibilities that has been undertaken by the group of Genoa and Turin. They studied 83 patients with hypercikemia. What they found was that about 25% patients were really affected by hypercikemia. If you look at the graph, you see that the majority of diagnoses were in the group of patients that have an increase of CK over 10 times, but also 5 times or more than 10 times were also recognized as in different categories like Duchenne, CPT2, lipid storage, RYR1, different kind of genes involved. And also the Italian group studied about 1,000 of individuals looking for with hypercikemia and or limb-girdle myopathy, looking for Pompe disease patients. And what we found at that time was that among over 1,000 of people, 17 patients were recognized to carry Pompe disease, and the majority of them were timely addressed to the therapy. If you look at this generated also a sort of algorithm where DBS, that we will discuss this later, was in the center of the laboratory determination of hypercikemia, and DBS was really very useful to start the recognition of patients with late onset Pompe disease. But this is a more recent, 2 years ago, paper done by the group of Giacomo Comi and other colleagues from Milan, and they studied something like 200 patients based on the use of NGS genetic analysis and in a group of patients with myopathies and or hypercikemia. You see here that 19 adult plus 49 pediatric cases, clinical presentation mainly elevated CK, but also accompanied by cramps and myalgia or variable degree of muscle weakness. The NGS was applied, looking for 54 different kind of genes, and this was the result. You can see here that 12% of the pediatric patients were recognized and diagnosed with different kind of involvement of genes, as well as 17% of the adult patients. This is not a very high number of detection, but several patients had an involvement of specific genes like RYR1, ETFDH, or LPIN, but other genes like CPT or ANO5 were also involved. And you see that those genes are quite well known already, and they were recognized, but there was a very high genetic heterogeneity among the different causes of hypercikemia. Many cases might not be monogenic. Environmental influence have been likely involved. Defined diagnosis was just over 15% of patients, but NGS is still a very key tool to identify hereditary forms. And here we can start to discuss about the new EAN guidelines for individuals with oligo or asymptomatic hypercikemia. What was the rationale to do this? So try to discover underlying myopathies, to have the possibility to start treatment timely and prognosis, of course, and enable genetic counseling. So this kind of project should be less invasive, high sensitivity, high specificity, and cost-effective manner. This was the task force that participated to and you see that there were people from every part of the world, including also the patient representative executive director of National Organization of Persons with Disabilities from Serbia. And the methodology is a quite now common methodology because we used the task force generated a number of PICOs, and we have very accurately tried to define the PICOs to be used in this search. There was a systematic review of the literature, and final recommendation was decided by the whole task via an online Delphi consensus. And it's important to remark that the recommendation were approved if there was at least 66% of agreement among different participants. Still, we included observational studies. The studies were included if genetic testing was used as reference standard. And I remind you that the patients included were oligo or asymptomatic patients with hypercikemia and only adult patients. So I will try to show you them in some details what we have found using the different kind of PICOs. And if you look at this PICO, for example, you see that here we said, should the repeat CK measurements be done after 3 days or after 1 or more weeks of limited physical activity to confirm hypercikemia? And this is the response. So there was a 86% of the task force, and the consensus statement was the CK should be repeated at least after 72 hours, but the preference is for repeat the blood examination after a week, of course, limiting the muscle efforts of the individuals, not to have interference in the determination of the real value of the CK. Then the second PICO was how many times should CK be measured to confirm hypercikemia? And here we had the 91% of the task force that agreed, and the consensus statement was CK should be repeated twice after the first measurement, and the 2 repeat measurements at least 1 month apart. So some of these statements were similar to the previous guidelines, but not exactly the same. And the PICO-free, what level of oligo asymptomatic hypercikemia should be investigated? There was a 83% of agreement by the task force, and the recommendation was to investigate in patients with at least 1.5 times an increase of the usual normal limits of CK. PICO-4 a little bit more complicated because we wanted to try to compare the use of evaluation of alpha glucosidase assessment by the BS or the determination of lactic acid or the fasting acylcarnitine compared to muscle biopsy to try to diagnose hypercikemia. So this was a very difficult search because no much studies were done in this sense in the past, but also you know that there is the tendency now to use much less the muscle biopsy, and the decision criteria were very low in favor of muscle biopsy. The DBS for Pompe disease was, when genetically confirmed, was very relevant to address the diagnosis toward Pompe disease. And this was a very strong recommendation to use 86% of agreement to use the DBS when you have to deal with the individuals with the oligo or asymptomatic hypercikemia. And the lactic acidosis is, there was a less great consensus, 71%, because the resting or exercise lactate testing for a metabolic myopathy is useful, but is not completely, cannot give you the complete results of diagnosis in this sense, mainly when you have to deal with the mitochondrial disorders, because you know that there are several categories. Could be long to discuss this specific problem of mitochondrial disorder, but you know that several mitochondrial disorders do not have an increase of lactate. And finally, the fasting acid carnitine, especially directed with patients with suspected lipid or metabolic myopathies, there was a consensus of 68% to perform this test when there was a suspect of metabolic myopathy, especially for especially lipid storage myopathy. Here, the PICO-5 in patient with the oligoasymptomatic hypercikemia. What is the diagnostic value of the neurophysiological examinations in terms of nerve conduction velocities and electromyography to differentiate the myopathic from the non-myopathic causes compared with muscle biopsy? And this was another quite surprising result, because you know that several groups are not much confident in neurophysiology, but the results was that 78% of the task force agreed on this recommendation to perform the complete neurophysiological examination, of course, to identify a myopathic or neurogenic disorder, to better address the diagnosis and then the therapy. PICO-6, in patients with oligo or asymptomatic hypercikemia, what is the diagnostic value of next generation sequencing or NGS compared to muscle biopsy with additional immunohistochemical Western blot investigations to diagnose the hidden cause of hypercikemia? And this was one of the most difficult decision, because at the end, 84% of task force agreed to recommend to use NGS, having excluded the acquired or neurogenic causes for these individuals. The seventh, patient with oleosymptomatic or asymptomatic hypercikemia, what's the diagnostic value of NGS versus targeted DNA testing, single gene testing, to diagnose cause of hypercikemia? And here, there was the 71% of agreement, but somehow the response was quite expected, because if you have some family where there is already a known mutation or is a high prevalence community, it's easy to look for, to use the targeted DNA testing, because you know that in that family or in that nucleus, in that cluster, there are already known mutations. Otherwise, NGS is really necessary to over single gene testing determination. Last PICO, in patients with the oligosymptomatic hypercikemia, what is the diagnostic role of muscle MRI versus muscle biopsy to diagnose the underlying cause of hypercikemia? And this was another very challenging discussion. 86% agreed, but in summary, the final response was to perform a muscle MRI in oligoasymptomatic hypercikemia because generally speaking, seems that MRI is more sensitive than muscle biopsy to address the diagnosis, the correct diagnosis for neuromuscular disorders, and this is a very strong recommendation. So, if we want to make a point about the different recommendation, I've tried to summarize all these results. And here we can say that CK testing should be repeated after at least 72 hours. But as I said, after a week is better. Of course, we need that the individual testing that has to have the testing should avoid to exercise, to use drugs or other factors that can change the CK level. This is a consensus, was a consensus statement. Another consensus statement was about the repetition of the CK testing in two different occasions, at least 1 month apart. And again, a consensus statement for the differences in terms of a higher level of CK when referred to the general levels we have been using for several times. So especially in Black individuals, the normal values are higher than Caucasian or Asian, and even Caucasian and Asian results are a little bit higher than previously considered. So we need to perform a detailed neurological examination, also to ask the family or relatives about neuromuscular disorders, to try to better understand what is the area of the hypercikemia. And if hypercikemia is confirmed, we need to consider neurogenic and non-neuromuscular causes. The last two, 4 and 5, were expert opinion, whereas about the use of DBS as a screening test for Pompe disease in a population of oligoasymptomatic hypercikemia, there was a strong recommendation. On the other, whereas a weak recommendation was the one regarding the use of neurophysiological studies to identify myopathic or neuropathic cases of hypercikemia. Also difficult was, as I said, but there was a consensus statement to perform lactate, resting lactate, non-ischemic forearm exercise to try to determine lactic acid level or the fasting acid carnitine levels. But it's very important to perform them if there is a strong suspect of metabolic myopathy, especially mitochondrial or lipid storage myopathy. Another strong recommendation was in favor of using of MRI of muscle, because it's very sensitive to pick up some less relevant muscle disorder that can not be evident from the clinical point of view. And finally, the use of NGS is highly recommended, apart from the cases where the families, the individuals are linked to specific families with no pathogenic gene. So another strong recommendation was that once hypercikemia is due to myopathic causes, NGS is recommended more than muscle biopsy. You know that muscle biopsy is also still very informative, but the use of muscle biopsy in the last few years has been limited to patients where the results of genetic study was not really exciting, or did not complete the diagnostic pathway. And muscle biopsy is still informative when genetic testing is not informative, especially for suspected metabolic myopathy, inflammatory myopathy, when there is an abnormal muscle MRI, when CK is quite elevated, or there is a family history of muscle disease, on there is a age of less than 25 years. So now I would like to complete the discussion about hypercemia. I would like to show you some practical case that I suppose that are somehow index case for different categories of hypercemia. And on the other hand, I would like to remind you that there is a clinical classification of hypercemia in mechanical and non-mechanical causes. For example, if you take mechanical causes, traumatic compression of muscles, excessive muscle activity, or obstruction of blood supply, we'll see in a minute, in a case of compartment syndromes, should be considered. And here, for example, we have a case of a man of 55 years old. The day before admission to the hospital, he performed a very intense physical exercise using a mountain bike. For several hours, it was impossible for him, after this exercise, to walk because of severe myalgia, rigidity, and muscle weakness. When admitted to the hospital, there was a very high level of CK, 6,500 at least, and he also had myoglobinuria. And the first diagnosis was hyperckkemia with myoglobinuria. We did electromyography that was normal, as well as we did the muscle MRI, and this was the results. Compartment syndrome. In fact, if you look, and after 5-6 days, he spontaneously recovered after disappearance of symptoms and normalization of the CK values. And you can look here at the MRI of muscle. There is a large edema at calf level, but even at the thigh level. But a week later, the situation was completely normal. And this is the cartoon that illustrates what happened in similar cases. There was a very high pressure done by the elevated CK in blood, and there was a pressure on the muscle fibers, and the vessels were really compressed for the increased pressure. Capillary is no longer functional, and this produces even a more important increase of CK. And one of the possibilities was to proceed with the fasciotomy. So there was an incision of skin to release the pressure, and not in the case I showed because it was not necessary, but in other cases was like that. But among the non-mechanic causes of hyperckkemia, you see that a big group is the metabolic myopathies group. And you can see here the glycogen storages. There are several cases of glycogen disorders with storage of glycogen. And this is a case of 2 years. This is a pediatric case, 2 years old girl, no consanguineous parents, no family history for neuromuscular disorders. At 1 year of age, she had a laryngeal inflammation. And she had a routine blood examination, and there was a mildly elevated CK level, 519. at 3 months, still a little bit elevated CK. Neurological examination normal. All the examination done normal, still CK elevated. And what we wanted to perform was the DBS for suspected Pompe disease, and the GAA activity, the alpha glucosidase activity, was really markedly reduced. You see here 0.39 compared to the normal values. In this case, we decided to start two ways. At the same time, we perform muscle MRI to go for a genetic testing, but we also perform muscle biopsy. Muscle MRI was luckily completely normal. Muscle biopsy was surprisingly quite compromised. 12% of of fibers were vacuolated, and there was an increase of glycogen and with periodic, demonstrated by periodic acids, the PAS reaction. And we performed also the biochemical assays. The muscle activity was very, very low, 3% in the muscle, also in fibroblast. In myoblasts, the diagnosis was confirmed by the gene analysis. There was the usual common change, mutational change in Caucasian plus a second mutation. This confirmed the diagnosis, but at that time, according to the recommendation, the EPOC recommendation for the treatment, the patient should start the treatment, was able to start the treatment only if symptomatic. She was not symptomatic. We continued to follow her. And after 7 years, there was a little change because she showed the scapular winging, a positive Gower's maneuver, here the scapular winging. And if you look at the numbers of the 6-minute walking test, or for example, 10 meters of the FUC, were not normal compared to the same age children. In this case, we decided to start the treatment. You see there was an improvement, immediate improvement in 60-minute walking test, and 10 meters, also CK went down, and there was a normal respiratory assessment. And this is the young girl now, when she is now 13. So you can see that she seems very, very normal. Big benefit from the enzyme replacement therapy at that time with the alglucosidase. And this is, but I don't, very rapidly, 6-year-old child. This is a different kind of disorder. Fatigability in walking, climbing stairs, waddling gait, Gower sign, very high CK level. He had also some erythematous eruption, neck, arms, elbows, and hands, and some bullous injuries at his fingers. You can see here. You see the classical Gottron sign. This is a very suggestive of dermatomyositis. In fact, the examination, the muscle examination, muscle biopsy, there were some inflammatory areas, and this was treated with the methotrexate with a very full clinical resolution in few months. So this was just to show you sort of different kind of not genetic but acquired case of HyperCKemia. I just want to remind you that also iatrogenic disorders can can start with HyperCKemia, for example, after use of statins, and you see the pyramid of different kind of disorders after statin use, starting from myalgia, going to myositis, myopathy, very high CK levels with rhabdomyolysis. And just to conclude, I would like to remark that HyperCKemia is a very challenging clinical condition because there are a large number of neuromuscular disorders that can provoke HyperCKemia. The majority of them are rare, and there is a frequent presence of unspecific symptoms. Important is to have some guidelines to address properly the clinical laboratory examination, especially to get timely right treatment and to improve their quality of life. This is the group that works in our place in Messina for this kind of disorders, and I would like to thank you all, and especially ERN that give me the opportunity to discuss about this specific topic. Thank you very much.
Thank you very much, Professor Toscano. Very nice presentation with important messages. And I look at the names in the attendees list and I recognize half a dozen of them that are younger than us, just half a dozen. And I would like to start by doing a kind of devil's advocate review of your presentation and ask you for your assistance in designing some workup of a patient arriving with myalgias and cramps to the clinics. So I imagine that probably that's something that you no longer see, but you know how to deal with it. So as you know, the majority of those patients are not serious patients, fortunately. But if I understood correctly, we do a CK. Then if it comes with at least 1.5 times the reference, we repeat it after 1 week, at least 72 hours. And then we still confirm it after 1 month, and we control for exercise, the usual things. And yeah, so after that, if it comes raised, if I understand correctly, even if you have the EMG machine side by side with you, you ask for MRI. Is that right?
Well, you're right, and your remark about if the neurophysiology is very close to you, it's important because I know that there are very good group interested in neuromuscular disorders. They don't use too much neurophysiology examination because of the length of delay in using this kind of examinations. But luckily, our neurophysiology is very close to our place where we see the patients, and we use neurophysiology continuously. And I can tell you that is not the best way to define, of course, the diagnosis, but it can help a lot because sometimes it's really difficult to select patients in the sense of different kind of neuromuscular disorders. I would say that sometimes myopathy with not elevated CK, motor neuron disorders, especially of adults, when compared, if you have the comfortable use of neurophysiology, can be of real help to address your diagnosis. Otherwise, the next move after having studied initially the patient is to definitely to work to NGS or targeted DNA study if there are other family members affected.
Okay, so that's helpful. So Felipe Villa has a question online. He can unmute himself and voice it, or I can read it. I'll start by reading it, and then he can unmute himself and argument. If you saw the same case of the young girl with Pompe's disease today at 2 years of age and without diagnosis, would you still go for muscle MRI or biopsy, or go straight for genetic testing and or DBS GAA testing?
Yes, this is a very accurate question, because I understood that you noticed that these procedures were done about 15 years ago, when still the NGS was not fully popular as it is now. So honestly, MRI is not difficult to be done in our place, and in any case, I would, after the suspect and DBS positive, today I would go definitely for NGS, but because NGS unfortunately is not in the same place where we are, and we need some more time. The use of MRI is very important for me, and I would recommend to use it a lot in neuromuscular disorders, because it's important to have also a point of reference when you, if you have to start the therapy, and you can have already a basic MRI, you can compare the result of therapy in the following months or years. So I think it's a very useful tool in this kind of disorders.
Excellent. So unless Philip has any comments, I will proceed. And you talked about the compartment syndrome in the context of rhabdomyolysis, something that it's not very unusual among young people, either sportive or military people. That happens quite often. But what about compartment syndromes in the context of metabolic myopathies, for instance? I've seen one this year, that's why I'm asking.
I think you have to publish this soon, if you have not already done, because it's very rare combination of problems. So compartment syndrome is an entity that still is not very well known, sometimes ignored or neglected. But it's important to think about this, to know that it does exist, really. Because in that case, if you are, again, if you have the opportunity to use, for example, MRI, you can get some more knowledge about this, and you don't need to go for genetics or for muscle biopsy. This is very important. You have just to wait and to hydrate the patient, because this is very important, to try to minimize the level of CK. But before proceeding with the fasciotomy or other procedure, especially if you have the chance to use the MRI to see if there is an edema, I wouldn't go for NGS. The case you mentioned, I don't know exactly what kind of metabolic myopathy was. I suppose the clinical situation is similar to any other kind of patient with compartment syndrome. I don't know if there was a specific complication done by the metabolic myopathy, possible, but I mean the clinical procedure, I don't think should be different.
No, it wasn't even, no. So one thing that was a bit under represented in this presentation was the muscle biopsy. As you know, in the past it had, we know, a better representation, or was used more often. But you presented a case of dermatomyositis, and in the inflammatory myopathies, do you think that muscle biopsy is less useful than MRI, for instance?
Well, honestly, I am quite old, and I still affectionate to the muscle biopsy. And I would say that sometimes, especially when the inflammatory myopathy is suspected, I suppose that well, you can again. I don't want to be obsessive with MRI, but MRI definitely in inflammatory myopathy is very useful because it's quite characteristic. But if you want to perform very good and accurate therapy for the inflammatory cases, I think that you have to take in consideration muscle biopsy. Still, you have to take in consideration muscle biopsy because the risk. So the other way is to use it's not genetic, so you don't use NGS. The other way is to use MRI, but MRI is quite informative, but not fully informative because there are other kind of disorder, neuromuscular disorder that can mimic the same expression of inflammatory myopathies at MRI. So, I mean, reasonably, if you have the chance to use a muscle biopsy, I would go for it.
Yeah, I agree, and I understand that it's a technique that is complicated, invasive, and requires dedicated expertise, but in some cases it's still probably useful. So I don't see any other questions on site, and so in that case, if you agree, we close it, and I will thank you again for your very kind participation and the learning that we have opportunity to acquire today through your presentation. And I'm sure we'll be talking soon in another webinar, sometimes in the future. Okay.
Right.
Thank you very much. Thank
Thanks
you,
a lot
Antonio. Okay.
Thanks a lot for
To
this
the
opportunity.
to the audience, please leave your feedback on the form. You have the link on the text on the chat. And thank you for attending, and see you next time. Bye.
Bye. Ciao.